Hello, welcome you to Cardiovascular Center in Hangzhou, China. My name is Jacek Legutko. I'm from Kraków, Poland, and I have the privilege and real pleasure to be here and to do cases with Professor JIANG Jun, really experienced operator. And please introduce your team.
So I'm Dr. Jun Jiang from Second Affiliate Hospital, Zhejiang University School of Medicine. Today we have Dr. Xu Cao from Hunan. He's also one of a fellow received training in our center. So today we have a very interesting case. Briefly, this gentleman, he had an acute inferior myocardial infarction 1 month ago and successfully treated with primary PCI in a local county hospital. So today we can see the RCA stent is well patent, and also the electrocardiogram it's only a small Q wave in lead 3. So it's actually the vessel is opened very early, so the myocardium, most of the myocardium are preserved. So today our target is lung diffuse lesion in left anterior descending artery. You can see there are two diagonals we need to protect, and very long diffuse lesion of this important vessel. So usually what will be your strategy for this kind of lesion in a young patient?
We discussed this extensively, how to treat this patient, and our decision was first to do it with physiology and intravascular imaging guidance to achieve as good as possible result according to ischemia, but also to optimize our stenting procedure. So maybe we can go immediately for wiring of these vessels, and then we will start with physiology.
Okay, so actually our fellow already wired this vessel with a samurai, and now we are start the FFR.
We will use in this case through physio microcatheter. This specially designed to measure intracoronary pressures, and this is the special feature of this device is that you can use it with every guide wire, 0.014 guide wire that you want to use for PCI, and you don't need to remove this wire. It will stay all along the procedure and can repeat many times and multiple steps of the procedure physiology measurements. It is really low profile design. Now 0 PDPA was done and the catheter is ready to be introduced. It is a long monorail system.
Yes, very tiny catheter.
Yeah. And very good profile. 0.020 is really low profile device. So there are two markers on the catheter. They have to be out of the guide. The proximal one is just the pressure transducer, so we need to equalize. The sequences of the procedure are very similar to what we do with pressure wires. The most important difference is that we use regular wires and we don't need to withdraw wire after the measurement. So we are going across the stenosis to the distal part of LAD.
I think that's just enough.
We can maybe start first with CRR, and you can easily see that we have significant gradient there. The value is 0.68, so there is definitely ischemia, which is maybe not so strange, but what we are interested in is to do the pullback, and we can do it now even with non-hyperemic gradient, because definitely we need to intervene. So we are slowly, Professor Jun is slowly pulling back this microcatheter across the stenosis. The value is still similar. So there is the most significant step ups are in the proximal part, of this vessel. So it's interesting.
Yeah.
You see that we have very diffuse disease. However, with this first measurement, the most important pressure gradient is across the lesion, which is in a proximal LAD from First diagonal just to the proximal LAD.
Maybe we do FFR.
Yeah, we do FFR now, and we can then repeat a pullback with during the infusion of adenosine.
给药吧，达利。
Has infusion already started?
Yes. 药已经开始给了啊。药已经起了。可能会有点闷啊，现在开始用药了啊。
Is it 140? Oh, 140 micro?
Yes.
Okay.
Now it's decreasing.
So now we measure FFR during continuous intravenous infusion of adenosine, 140 microgram per kilogram per minute.
一会儿就过去了啊。
Patient,
稍微坚持一
of
下啊。
course,
不要紧
feels
张啊。
some chest discomfort. And as you see, the FFR value is 0.56, 58, 55, so it's really very significant.
开始回测。
According to outcome of the patient, this is very good indication for revascularization. And again, Professor Jun is pulling back the catheter, and again there is no such gradient across the mid part of LAD, and the most significant gradient is across the proximal LAD. So it is quite similar. Maybe now we have some drift.
不要紧张啊，放心。
But we don't need to repeat it because it was painful for the patient. I believe that this is for sure significant disease there. We will of course recalibrate. We will do another equalization before next measurements. But I believe that we can trust this assessment. We have very long diffuse disease,
看一下，拉一下。
but most significant one, according to physiology, seems to be in the proximal part.
And
So
also
it would
okay.
be-
Before
yeah.
maybe some
Now
movement
it's
of the
okay.
guiding caster.
Yeah, maybe it was caused by guide. Yeah, you are right. So our decision was also to do intravascular imaging in this case because this is young patient, long diffuse disease. We would like to treat it as good as possible according to achieve the good long-term outcome. Yes, you are in. So for today, we will use a high definition 60 megahertz True Vision catheter from Inside LifeTech company. So you see now the preparation of the high definition IVUS catheter. The special feature of this device is the long pullback, 15 centimeter pullback. So you can, with one pullback, you can assess all along the vessel. And there are 4 speeds of the pullback available: 0.5, 1, 5, and 10 millimeter per second. So especially in very tight lesions, you can shorten the time of the evaluation. However, afterwards, when we want to have very detailed analysis, we usually go for 1 millimeter per second.
So our first round we will use 10, right? For this.
As a first, yeah, usually 10 because it is tight stenosis and we can expect some ischemia during the evaluation. So, yeah. Yeah. We have some artifacts, but now we are in a distal LAD. You see the vessel here is okay, and it's like 2.5 vessel in diameter. And now we pull back, and you see immediately very diffuse disease there. But of course we need to carefully assess. Now we can withdraw the catheter from the artery, not to limit the flow too long. And now we can assess and measure. There are two additional features of this technology which are really good. First, we have online co-registration available, which takes like 1 minute to do it, which is not so bad. And at the same time we have automatic assessment, quantitative assessment of the vessel, which is coming with this device. So now we do co-registration, and this is very easy then to be really sure where we are. You see that blue marker on angiography, which tells us where we exactly are with our probe, and you see the very diffuse disease all along the vessel up to the proximal part. And of course we have tapered vessel because there are many branches, including 2 quite large diagonal branches. Distally this vessel is like 2.5, and in the proximal part is close to 4, which is maybe 3.5 at least in the proximal reference segment. So first of all, probably it would be very difficult to treat it with only one very long stent.
Yeah.
We need 2 stents, which is also better because we have 2 bifurcations. So first we can treat with long 2.5 stent across second diagonal, do the pot, and then use another overlapping stent in the proximal part. What do you think?
Yes. 测量一下第一个支架到那个远端那个对角是几毫米？来个2.5 20的预扩。So the distal landing zone to this Y is length is 35.
Now we see some measurements, and we also measure the length which is possible with this system using automated pullback. So definitely distally to the diagonal branch there is quite long segment. It's close to 4 centimeters, but all along the vessel it is much more, of course. So what would be your strategy now after predilatation?
We'll implant stent distal to the Y protect diagonal, and also use geoprone technique to protect this branch when we deliver the proximal stent.
Out of the ostium in the proximal part doesn't look so bad. We can of course check on IVUS. This is ostium of LAD.
Maybe IVUS again, okay. Here no symptom, I think should be fine. Hemodynamically stable.
So we have flow.
So this time maybe we do a slow pullback.
Because we need to decide and appropriately measure the length of the stent for proximal LAD. So we will measure just from the proximal edge of the stent which was already implanted distally, and then we will find appropriate landing zone in the proximal part, and with this high definition mechanical IVUS and automated pullback we will measure the length of the stent. Definitely it has to be at least 3/0 stent, and then we need to do also pot proximal to the second diagonal branch after stent's implantation. Now you see we are in a stent which is distally well expanded. Maybe we need some high pressure post dilatations afterwards, and we see diagonal branch, and then the stent is of course undersized, so we need to do pot, but we can even try to do it with the balloon from the second stent, which would be 3/0 balloon. Yeah, and here we see the proximal segment of the vessel with positive remodeling. We have a lot of calcium there, but there are no circumferential calcifications, and we have some rupture here. So predilatation was probably a good one. And somewhere here we have a good landing zone, I believe. So this at the level of this small side branch. So we will measure the length of, we don't need to cover probably this very proximal part of LAD. There is also plaque there, which is protruding into left main, but without stenosis. So we don't want to touch this. So please do the measurement. First, the distal marker, just not with, on the stent, 1 millimeter inside the stent, because we need to have overlap.
28差不多到。3.0 28沙里，近端是在间隔一远还是已经啊？看有个很小的间隔。一远1-2毫米可以。嗯。What about the distal landing zone? A little bit plaque? 有，好像是不是有一点点斑块啊？
就是有点斑块。
可能不够远一点。斑块负荷多少？你看一下。
38。
So after this high pressure post dilatations, Professor John decided to use IVUS to check the stent expansion. So you see how it easily crossed all the lesions and stents implanted in the proximal and mid part of LAD, and now we are distally at the just at the distal edge of the stent, so we can push it a little bit maybe forward. Okay, so the distal stent is well expanded. It's, of course, there is the plug outside of the stent, but it will stay there. We are concentrated on the lumen, which is good, all along the vessel. Patient is still asymptomatic. Diagonal was probably okay, and we have this tapering. With this post dilatation, you achieved good tapering of the stents. Proximally, we see the lumen, which is at least more than 3.0. And the proximal edge, it's not so bad, maybe a little bit of under expansion, but we covered what we wanted to cover. So the length of the stent is appropriate. We didn't touch this plug which is in the ostium. So according to IVUS, it doesn't look so bad. However, you can measure with automated assessment what is the minimum in-stent area. So you should mark distal edge of the stent and then proximal edge of the stent, and let's try to calculate the lumen area inside, what is the minimum lumen area with automatic assessment, which is now performed, and we will check for minimum in-stent lumen area, which is 4.48. And we have some small zone of the lumen area which is below 5.5, but it's not too long, and it's in a small vessel because this is distal reference. So Professor Jun decided to check this result with physiology, which again, with true physio is very easy because we use the same wires that we have. PDPA is 0.92, but definitely we can change into CFR. What is the CFR value first? So measure non-hyperemic, which is quite okay. It's 0.9, so it means that we achieved a good result according to non-hyperemic parameter. However, we have very long segment of LAD which was stented. So I believe that we can repeat also FFR assessment with IV adenosine, and then we can check the pullback. So have we started adenosine?
Yes.
Infusion. So we have started infusion, and we calculate FFR value, which is 0.91, but it is not maximum hyperemia. This patient is symptomatic to adenosine, so he will tell us. Yeah, he will tell us, and we will know where we have the full hyperemia.
I think it's quite good. Almost stable.
5, which is again, we would love to achieve more than 0.86. Yeah. But 0.85 is not so bad. So now Professor Jun is doing pullback. Okay. And it looks like that we have not significant gradient across the stented segment. We have just some residual gradient across the ostial LAD, but it is quite diffuse. And of course, it is also important that we want to treat this. We need to go for left main stenting. In case of good luminara, not the very big plaque burden, and only small gradient there, and very good result according to physiology and intravascular imaging. I don't know what is your opinion, but maybe we can just finish this procedure. What do you think?
Yes, I will finish.
Okay, Professor Jun, we can assess this as a very good result by angiography, but what is even more important, in the beginning there were some discrepancies between physiology assessment with the pullback, because there was almost no gradient in the mid part of LAD and very severe gradient in the proximal part. But with IVUS we confirmed there were angiographically tight stenosis, a lot of diffuse disease. So your decision was to cover all the proximal and mid part of of LAD with stents, and it was good decision. And then you did this overlapping stenting, optimized stenting with high pressure post dilatation with balloons sized according to IVUS. And at the end, we have not only optimal result by angio, but also by IVUS, and especially by physiology. And then the distal, there is no ischemia there, but the more important is that when we do pullback, we have no significant gradient across all along the stented segment of the vessel. There is only some residual gradient across the ostial LAD, which is not tight, and there is no need to intervene now and to do left main stenting on that vessel. So congratulations for excellent procedure.
Thank you.
To all the team. Thank you very much.
Thank you.